Now let's talk about the narrow complex irregular tachycardias. So there's three that we should know about. There's atrial fibrillation, atrial flutter, and multifocal atrial tachycardia. Starting with AFib, this is probably the most common tachycardia that you'll see in the hospital. If a patient is having some kind of tachycardia, it's most likely going to be atrial fibrillation in RVR, which means in rapid ventricular response. You've probably had many lectures on atrial fib already, but clinically, the main things to know about it are how it looks on an EKG and what are the causes of it. So on an EKG, you don't have any distinct P waves, and the QRS complexes are irregular. And that's because there's multiple foci in the atria that are causing these depolarizations, so you don't have a clear distinct P wave, and those foci are kind of going through into the ventricle at irregular intervals, causing these irregular QRS complexes. The main etiologies that can cause this are infarction, hypertrophy of the left atrium due to either hypertension or mitral stenosis, alcohol, thyrotoxicosis, patients that have had surgery such as a CABG can have this, and also PE. From a clinical standpoint, the three things or four things that are very important are MI, alcohol, thyroid, and PE. MI and PE are ones that are often missed, especially PE, because sometimes these patients just start having a bit of a atrial fibrillation RVR episode in the 120s, 130s, and we treat it and might go down or we increase our medications, and they persistently have this tachycardia and we don't think about a PE. So that can be one of the first signs. So always kind of keep that on your differential whenever you're treating patients with kind of worsening AFib or new onset AFib, is that they might have a PE. You also want to rule out that they're not drinking or that their thyroid levels aren't causing this. So let's look at an example here. Here we see that this is a narrow complex, irregular tachycardia because the QRS complexes are kind of occurring at their own rates. Looking for P waves, we don't really see any regular P waves. We see kind of some of these atrial depolarizations here, but they're not necessarily that regular. So this is kind of an example of atrial fibrillation in RVR with rapid ventricular response. You see that there's a lot of QRS complexes that are irregular. They're sometimes close together, a little bit wider apart. If you were wanting to determine the rate of this, you usually would have to count out the number of QRS complexes in this EKG because you can't use the box method because it's an irregular rhythm. In terms of treatment, the main medication that you'll see used in an acute setting whenever you're taking care of patients with AFib and RVR is metoprolol. The dose is usually 2.5 to 5. I write here 2.5 for older adults because a lot of patients that are older are very sensitive sometimes to metoprolol, and I've seen this myself. I've given metoprolol like 2.5 to a patient who was in his 80s for AFib with RVR, and he actually had a pause for 8 seconds. And literally, my fellow and I would keep on looking at the monitor and back at the patient during those 8 seconds because we were concerned that this patient might just go into asystole. But what was actually happening was he was very sensitive to the metoprolol dose that we gave him. So in older adults and patients that are frail, it doesn't hurt to start with these 2.5 milligram dose of IV, but in all their patients, kind of giving 5 milligrams is also okay. And you give it about every 5 minutes. Also, you could give diltiazem. Usually you kind of see it given with a 20 milligram IV dose, and then sometimes followed by a drip. However, the important thing to note about diltiazem is you don't want to give in patients with heart failure. You do still kind of see it used in patients that have heart failure, but it's not really recommended because you don't want to use calcium channel blockers in heart failure. The other medications that you could see used in AFib with RVR is if patients are responding to beta blockers or not responding to calcium channel blockers, you can start amiodarone, and the dose is usually 150 milligrams over 10 minutes, and then you start a drip. And other things that you might be seeing used is digoxin, though digoxin has a narrow therapeutic window in patients on different medications or that have CKD. You really have to follow the dig levels, or you could start an esmol drip. These are some of the medications that you kind of use for AFib, but the other thing that you should always remember whenever you're treating a patient with AFib with RVR is that they will likely need anticoagulation. So if this is new onset AFib, they likely need anticoagulation. So kind of remember those two things. You not only want to treat the rate, but you also want to probably start them on or consider starting anticoagulation. The other narrow complex irregular tachycardia is atrial flutter. An atrial flutter can actually be a narrow complex regular tachycardia. We put it under irregular just to kind of clump it together with AFib, but it can also present as a narrow complex regular tachycardia. Atrial flutter on an EKG presents as these sawtooth P waves. The trick to kind of seeing these P waves is actually to flip the EKG around, which we'll show you in a sec, because that kind of helps you see the P waves a little bit better. Atrial flutter is one where kind of the heart rate could really help you determine if this is atrial flutter or not. So if atrial flutter is conducting 1-to-1, you're going to see QRS complexes beating at 300 beats per minute, which is really quickly. If that's the case, these patients are likely going to decompensate really quickly, so you usually don't see that often. The most common are these 2-to-1 atrial flutters, where the heart rate's beating at 150 beats per minute and it's not really changing that much. So if you have a patient come in with a heart rate, or they develop a heart rate in like the 145s or 155s, and they're just constantly staying there and they're not going up, they're not going down, think about atrial flutter as being the etiology. You also could have higher blocks where you have 3-to-1 or 4-to-1 P waves to QRS complexes, and those would have slower rates of 100 to 75 beats per minute. So in terms of etiologies for atrial flutter, they're similar to AFib, but they can also happen without structural heart disease. So they can kind of just happen based on the conduction system that patients have. One of the words you might hear is the tricuspid isthmus, which is kind of the area where typical A flutter could originate, but that's nothing you have to really memorize. It's just kind of where, in terms of electrophysiologists, the EP doctors, what they can ablate or kind of look for ablation when they're doing a procedure to treat these patients. So let's look at an EKG here. Here we actually have this narrow complex, and it's a regular tachycardia, so this one's not irregular, but we see kind of this sawtooth pattern. And in a typical A flutter, you actually have negative P waves in 2 and 3. So to see those a little bit better, you have to flip the EKG. And once we flip it around here, we actually see this nice EKG pattern. And this patient actually has a 4-to-1 block. It's sometimes hard to kind of figure out whether this is like 3-to-1, 4-to-1, 2-to-1, but that's where the heart rate could really help you out. So here we have 1, 2, 3, and the fourth P wave is actually buried here in the QRS complex. So this would be a 4-to-1 block. Looking at another example here we actually have an atypical flutter because the P waves are positive in 2 and 3, and you see how this is an irregular narrow complex tachycardia. So this is actually an A flutter with variable blocks. So you have this 4-to-1 to 2-to-1 to 4-to-1 to 2-to-1 to 4-to-1 conduction of the atrial flutter, and that's what makes it irregular. So that's why I kind of put atrial flutter under the narrow complex irregular tachycardias, because it could kind of be either or. Looking at another example of kind of variable block with A flutter, here this was one of my patients in the ICU that didn't really have the best kind of discrete P waves, but they were having a typical flutter. So if you see here, there's a narrow complex tachycardia, but it's irregular. But if you flip it over here, you kind of start seeing the sawtooth pattern a little bit better. And this patient was kind of intermittently going from 4-to-1 to 2-to-1 atrial flutter. So this kind of goes to show that the P waves aren't always that clean, but the heart rate and kind of the spacing of the QRS complexes can help you differentiate the type of flutter that this is. The treatment for atrial flutter is the same as it is for AFib, so you can use metoprolol, you can use DILT, you can use amio, you can use digoxin or esmolol. But the thing is, sometimes if these flutters are like 2-to-1, or even if they're 1-to-1, It might look like SVT because it's a narrow complex irregular tachycardia. So these patients might get adenosine. And when they get adenosine, what happens is during that kind of pause section, you see the sawtooth P waves, and that's when you have the diagnosis. The key with treatment for many of these patients is once you rate control them, ablation can cure them 95% of the time. So it's actually one of the main referrals that you would give for a patient if they have a newly diagnosed atrial flutter, is to see a cardiologist, to see an EP specialist, to see if they should be considered for an ablation. Lastly, the other narrow complex irregular tachycardia that you could see is MAT, or multifocal atrial tachycardia. Here, if we remember from our boards, this is where we have the three distinct P-wave morphologies. And the key is that the intervals, the PR, the R, and the PP, can all vary. The main thing to look out for in these patients is usually caused from lung disease, and that's how it is on tests, is patients with COPD all of a sudden have this EKG that has these different P-wave morphologies. You should be thinking MAT, but heart failure can also cause that. So looking at an example here, and looking at the P waves, we see that this first P wave is different than the second one is different than the third is different than the fourth, and then the fourth and fifth are kind of similar to the first one, but we can clearly see that there's different P wave morphologies. So this would be MAT. The treatment for MAT is the same as for atrial fib, it's the same as for flutter. You give beta blockers, you give DILT, you give esmolol, and you want to treat the underlying cause. So those are the narrow complex irregular tachycardias. Now we're going to talk about the wide complex.